Good afternoon. My name is Deanna Roberson, and I'm going to be discussing cognitive behavior therapy, CBT therapy, as an effective means of treating depression in adults. Depression is a mental illness that affects millions of people. Here alone in the U.S., 18.5% or 1 in 5 adults report having experienced depression. Depression is characterized by feelings of hopelessness, helplessness, unworthiness, prolonged sadness or guilt, low energy, poor appetite, inability to engage or sustain in relationships, and/or sleep disturbances or insomnia. Untreated or poorly treated depression, in conjunction with environmental influences, can lead to maladaptive coping behaviors such as suicidal or homicidal thoughts, substance use, job loss, homelessness, and/or poor relationships. Depression is also a major precursor to suicide, which is the 10th leading cause of death in the U.S. and costs the nation over $70 billion yearly. Suicide can further lead to a perpetual cycle of unresolved grief and depression among the surviving loved ones. Various forms of psychoeducation have been used to treat depression. Cognitive behavior therapy has been suggested as the first line of therapeutic treatment for depression, used alone and/or in conjunction with medications or other holistic treatments. It is a guided short-term behavioral intervention that includes skills training, exposure, and problem solving. Findings by Haller et al. 2019 and Gao et al. 2016 both noted that groups receiving CBT had reductions in depression scores within 6 weeks of treatment and demonstrated greater improvements in quality of life in terms of general, physical, and psychological health and social relationships. Haller further noted that participants expressed a sense of control, freedom, stability after having acquired the tools to cope with mental illness. Baker's title model supports empowerment-based recovery. It uses sea imagery to distinguish stages of mental crisis and safety or recovery. Water is the core metaphor. Life is understood to be unpredictable and ever-changing. Individuals move through life in 3 dimensions. Number 1, the worldview, which values the need to be understood and validated. Self-view, which stresses the need for emotional and physical safety. And finally, others, that seek support systems needed to maintain stability. In essence, this model is patient-driven recovery. Beliefs about self, roles, and abilities and subsequent maladaptive behaviors and reactions change in relations to storms and safe havens. Individuals start to have better relationships with themselves, the world, and others, thereby reducing symptoms of depression and suicidal behaviors. To implement this proposal, individual self-referrals and those from mental health and primary care providers will be taken and evaluated by administrative staff for inclusion criteria. Inclusion criteria includes adults aged 18 above with a validated diagnosis of depression. Exclusionary criteria includes having co-occurring mental illnesses, active substance abuse, impaired cognitive abilities, and concurrent participation in a clinical trial for depression. During the initial stage of intake with the RN, participants will be given a PHQ-9, a brief questionnaire depression assessment tool to complete. The PHQ-9 assesses and monitors for the severity of depression and treatment responses. It contains 9 items that are each rated from 0 to 3 on a Likert scale, where 3 is not at all present, where 0 is not at all present, and 3 is nearly every day, resulting in a score from 0 to 27. Those scoring 5 or above will be referred to a licensed provider, such as a nurse practitioner or social worker, for further depression screening, using the DSM-5 as a reference guide to validate depression. Individuals scoring 15 or above, indicating moderately severe to severe depression symptoms, will be referred to a psychiatrist to evaluate the patient's ability to participate in treatment. Those who meet criteria will be offered the opportunity to participate in twice-a-week groups or individual CBT therapies on site at an outpatient facility or via Video Connect for 3 months. 30 individuals will be randomly chosen to participate. Midway through the intervention, participants will be given the PHQ-9 again to measure depression scores. At the end of 3 months or post-intervention, the PHQ-9 and a patient satisfactory survey will be given to participants. Outcome measures such as reduced depression scores will be measured using the PHQ-9. Data collected pre, mid, and post-intervention will be analyzed for any reduction in depression scores. Patient safety data will be grouped and analyzed based on quality of life values, such as health, lifestyle, relationship, environment, and self-perception. Patients will be asked to identify elements that were helpful and or created barriers. Again, the goal is to move from disempowerment to empowering in order to have better relationships with self and gain a higher level of consciousness. From beginning to end, this process will take 5 months. The first month and a half to train staff, recruit and enroll patients, and secure internet access codes. The next half of the second month is to acclimate patients with the environment and treatment guidelines and stage on-site rooms for CBT therapy. Months 3 to 5 is for facilitation of CBT sessions. During this time, participants will meet on twice a week to engage in CBT therapy with their facilitators. At the end of 5 months, at the end of month 5, participants will be given the option to continue CBT therapy with or without monitoring for depression. Thank you.